welcoming and introductions because we have a very exciting workshop type program today. And I want to leave plenty of time for any discussion and there will be time for interaction and discussion. So welcome everyone to our HIV Center Round series. And today we have a very special event that is, it's like a rounds, but it's also like a panel and workshop. So just a little bit different from our usual format, but we will conduct it in the same way. Before I introduce today's presenters and presentation, I will announce our next few rounds coming up, 2 in April, as we usually have 2 a month. On April 4th, we have Dr. Morgan Philbin, who is, many of you know, who was until recently with us at Columbia, is currently at UCSF. And we don't have an exact title, but she'll be focusing on long-acting injectables in HIV prevention and treatment. And then on April 18th, we have one of our double billings with 2 of our current research fellows, postdoctoral research fellows. And that'll be Dr. Kirsty Sivright and May 10. We'll be presenting on April 18th. Still working on their titles. I'm sure they'll both be exciting. And then I'll mention one more at the beginning of May because it's on May 2nd. And then we have Dr. Jerome Singh presenting on research gaps and associated ethical legal challenges in high burden HIV settings in Africa. So those are upcoming events, April 4th, 18th, May 2nd. Hope to see you at all of those. All right. So today, as I said, we're very excited to have this panel of folks, all part of and helping run our HIV Center. And I'm going to do a very, very quick intro for each one of them and then turn over to the group of 3 of them. So we have Dr. Justin Knox, who is an assistant professor of clinical implementation science and intervention in psychiatry at Columbia University. His research focuses on HIV and substance use among racial and sexual minorities, both domestically and globally. We also have Dr. Jennifer Mootz, a licensed psychologist, assistant professor of clinical medical psychology and psychiatry at Columbia University, and a research scientist at the Research Foundation for Mental Hygiene, New York State Psychiatric Institute. Her NIMH-funded research has focused on reducing the global mental health and substance use treatment gap in low-income and humanitarian settings internationally and in the US through digitized innovations and consideration of social determinants of health. And then last but not least, and actually Dr. Aimee Campbell is going to kick us off on this trio. So Dr. Aimee Campbell is an associate professor of clinical psychiatric social work in the Department of Psychiatry at Columbia University Medical Center and a research scientist in the Division on Substance Use Disorders at the New York State Psychiatric Institute. Aimee's research focuses on the development and testing of individual and program-level interventions for substance use disorders and co-occurring health and mental health challenges, including the leveraging of technology-based platforms with the objective of increasing adoption and effective implementation for best practice treatments. So as you can see, there's a lot of synergy among their expertise and what they do. And with no further ado, I will turn it over to you, Aimee.
Great. Thank you so much, Bob, for the nice introductions. And thanks very much, everyone, for being here. Let me get my slides up.
And sorry if I just didn't, I sort of hinted at it. Even though this is a 3-person format, we're going to have similar to other rounds where we'll be holding our questions and comments till they've all presented. And then there will be room for, as usual, for questions and discussion. Thanks.
Great. Thanks, Bob. All right. Are we seeing the appropriate screen?
Yes, we can see it.
Yes, we
Great.
are.
Thank
you.
Great. All right. Well, good morning, everybody. It's really, really wonderful to be at the HIV Center rounds. Justin and Jennifer and I have been meeting multiple times over the last few months to talk about this workshop and kind of how we wanted to share some of this information, and but also primarily to really hopefully engage folks in a discussion at the end around some of the concepts and ideas that we'll be presenting, but also to hear about your own work and how you're thinking about integrating implementation, and I think more broadly, trying to maybe focus a little more on external validity issues in your work across the continuum of research. So I'm going to kick us off this morning, and my goal is to really just provide a kind of a foundation and framework for this discussion today. And then Jennifer and Justin will provide some kind of specific examples and walk through some of their own research and how we're thinking about this. And then we'll get into some discussion. So without further ado, I have no disclosures. And then this slide just gives us some direction for today. So I'm going to try to hit the first couple of bullet points and start to get into the third bullet point. But Jennifer and Justin will really do that one more justice. And then, kind of our primary goal is really to enhance the dialogue within the HIV Center on ways to expedite the integration of best practices into routine practice. Through the use of implementation science and implementation data collection throughout the translational science continuum. So, just a small little area that we're hoping to focus on today. So to get us started with just a quick overview of implementation, and this I'm sure is kind of pretty familiar to everybody who's joined us today, but just to get us all on the same page. So implementation science was really developed, at least in the social sciences, to help address the no-do or the implementation science gap, right? This is what we all know, the seminal Institute of Medicine report in 2001 with the 17-year estimate between something being developed in research and actually rolled out to any sort of scale in the community was close to 2 decades. And I think, and we can talk about this, but I think that's probably pretty close to where we are still today. Maybe we've made a few gains. And most of the NIH institutes talk about this. So the quote on this slide is from NIDA, but they talk about this bench to bedside, no-do, implementation science gap, and then it's really one of the key issues that we're trying to address in our research today, to get evidence-based practices out into the community, into the hands of the folks that can really benefit from them. So implementation science helps us to do this. It provides us with models of determinants, processes, strategies, with the goal of shortening that no-do gap. So on this slide is just a pretty common definition of implementation science from Eccles and Mintman. And it's really the scientific study of methods to promote the systematic uptake of evidence-based practices into routine care, and specifically with the goal of improving quality and effectiveness of health services. And in preparing for this talk, I was looking around because I've used this slide a lot over the last decade or so, and I was looking to see, has anybody improved upon this basic implementation science definition? And I couldn't find one that was better than this, that was as simple and straightforward. And so I think this is a good overview of what implementation science tries to do. And we know that it's important to consider multi-level factors that influence implementation, and we'll talk a little bit more about that. So what we want to do, move towards today is how to integrate implementation science kind of earlier in the research translation continuum. So as I mentioned, we do have at this point multiple well-tested models and frameworks to help us think through the complexity of implementation efforts. So this is a really nice review by Nielsen and colleagues that came out in 2015, kind of categorizing the different types and purposes of implementation frameworks. And so the top two lines are really, some of the classic theories related to implementation. There are specific implementation theories that folks use. But I think for our purposes today, and really thinking about research that integrates implementation science, we're most focused on the determinant frameworks, the process models, and the evaluation frameworks. And so the determinant frameworks and CFIR or CFIR is a very, very common one. Paris is another one. These really get at what are the barriers and facilitators that influence implementation success. So what are the different factors that can help get something into routine care and sustained over time, and what gets in the way of that? What are the barriers? And these are often, this is a very common part of implementation science. It's probably the thing that is most researched, and the data that's most collected are looking through some of these influences. Process models basically ask, how do you implement something? What are the practical processes for actually standing something up? And then evaluation frameworks. What are the outcomes of implementation efforts? How do we measure implementation? And how do we know that what we're doing is successful and sustained over time? And of course, RE-AIM is a very common evaluation framework. So we'll just go into each of these very quickly. Again, just to kind of give us a sense of how these fit into both the hybrid models of implementation effectiveness that we're going to be talking about, as well as thinking about how do we utilize these models earlier in the translational science continuum to collect this data. So this is a visual of the Consolidated Framework for Implementation Research, or CFIR. And this is 2.0 that was released in 2022 that took all of us some time to get used to. And I'm now a full believer in 2.0. So the Consolidated Framework helps us, again, to systematically think about the barriers and facilitators that influence implementation success, and it looks across these 5 kind of multi-level domains. Similar to kind of other ways of thinking about, kind of the biopsychosocial context and different multi-level sectors that we all work within. You have kind of the individual level. This can be providers or consumers, patients. You have the inner setting, which is really within the organization or health system. And then you have the outer setting, which is really all those things external to the organization, including both local, state, federal policies, et cetera. And then the other 2 pieces of CFIR are the implementation process and the thing. The thing is what CFIR 2.0 calls the evidence-based practice, the intervention, the innovation. And each of those also has constructs attached to it that we can measure. So this just kind of helps us to think about the context in which we're working and gives us a pretty good roadmap for some of the things that we may want to think about measuring in terms of barriers and facilitators to getting something implemented. Not every study has to capture all of these things. It really is dependent on what you're doing and the context and where you are in the research process, and you can select, a couple of these to focus on in any given research project. So this next slide talks about the implementation strategies, and implementation strategies are really a component of the implementation process. So the process kind of talks about maybe the different phases of implementation, like the EPIS model is a good process model, looking at exploration, preparation, implementation, sustainability, these phases of the implementation process. And within each of those phases, we can select implementation strategies to help us integrate that evidence-based practice into whatever setting we're in. So implementation strategies are how we seek to get the thing integrated into routine practice. So you can select one strategy to test, but often it's a package of strategies that people use to really help to implement an intervention. So examples of this are, you can identify and prepare a champion to lead the effort. You can utilize external facilitators to support the implementation team. You can provide training for staff. You can adapt workflows. And so all of these, and so those could be kind of a package of strategies, or you can test just one. And Powell and colleagues have really worked to identify and categorize science-based strategies that facilitate implementation practice. And so this table shows the 6 major categories of strategies with a brief description of each. And then within each of these categories are a number of specific strategies, like I just mentioned. Strategies can be selected based on what's worked in similar settings and tailored based on local needs. And implementation process outcomes and implementation strategies can be explored and tested. And I think one nice way to think about, well, what is it that we're looking for in terms of testing implementation strategies? We can think about kind of the speed of implementation. So do some of these strategies help to expedite the implementation process? We can think about the quality of the intervention delivery. Which strategies help us to actually implement better? And then you can maybe think of the quantity of that implementation effort. So which of these strategies can help us to increase the reach of these interventions, get them to more people? So really thinking about strategies in terms of how do we measure the success of those? And that data can be used then to monitor the implementation process. Okay, and then finally, here's the RE-AIM evaluation framework. And I'm guessing any folks that have done implementation are very familiar with these. This is a nice framework, I think, in that it's quite simple. It's somewhat easy to understand. I know some of the implementation frameworks and models are challenging. They're very complex because this is a complex issue. And so these evaluation frameworks really help us to know how our implementation efforts worked and for whom. Have they been sustained? And have they been sustained with ongoing fidelities? Those are some of the questions that we can ask and answer. And I would just note in terms of implementation outcomes, equity is an integral part, and all of these outcomes can also assess how we're doing in terms of improving equity. That our improvements, our integration of the intervention is working similarly for everyone. Okay, so just to switch slightly into thinking about, okay, how does this all work within the translational science continuum? So we know that implementation is off to the way I think about it visually is off to the right. It's way down the line, right? Implementation research after we do all these other things. And the visual here kind of gets at that a little bit. So, and implementation science is important because it can get best practices successfully integrated into routine clinical care. And we do have those well-researched frameworks and models to guide us. But still, there remains an inherent delay in getting those evidence-based practices out into the world and scaled up. So this is where we kind of wanted to focus our discussion today is, okay, how do we now make better use of this translational science continuum? So I think there's general agreement, and that this is a fair place for discussion as well, that we now kind of come to the conclusion that it's often unnecessary to keep efficacy, effectiveness, and implementation research so separate and so sequential, rigidly sequential, maybe we could say. That this somehow overlooks the complexity of the world in which we live and where our interventions are going to end up being delivered, and it slows the research process. And so how do we think about kind of novel ways to integrate some of these steps to speed up the research process? So this slide shows, kind of the traditional kind of linear model of preclinical studies through efficacy, through effectiveness, and then into dissemination and implementation. And some of the issues are that, different researchers have tended to work on one end or the other of this spectrum. So EBPs often get dropped between that effectiveness and implementation step. So we'll do the efficacy and the effectiveness work, we'll do some relatively passive dissemination, and then it's someone else's job to get these things out into practice. So that's one area that I think we can talk about. How do we become better at straddling that divide between effectiveness and implementation? We've also relied heavily on dissemination mechanisms without enough information on how our interventions will work in communities. So even though we're disseminating and say this is how they're used, we haven't actually done a whole lot of research, in community settings with community providers delivering the intervention. And we haven't had good knowledge about how adaptation and tailoring works within different context settings or with different populations. So by not concurrently gathering effectiveness and implementation data, we often find ourselves unaware of kind of crucial contextual factors related to the success of interventions. And this risks further delays in implementing clinical interventions. So we're going to talk about just a few ways to think about how to move us more quickly through this continuum, including using implementation data earlier in the pipeline, as well as thinking through the hybrid type trials. Again, which I'm guessing many of you have had some familiarity with, if not utilized some of these study types in your own research. So in 2012, Curran and colleagues published their seminal paper on hybrid effectiveness implementation research. And I'll just note in their more recent publications, they've suggested moving towards using the term study as opposed to design. There was a lot of confusion that a hybrid type 1 was the design of the trial, but it is more of a type of trial, and then you have to select an appropriate design based on whichever hybrid type you're using. So they now call them hybrid effectiveness implementation studies. And across these three types of hybrid studies, you can decide on a design after selecting the type. And there can be, as Justin's going to talk about, well-designed observational trials along with our more standard, kind of randomized controlled trials. And specific research designs are needed to test or evaluate effectiveness and implementation. And those should really be, again, selected based on the research questions themselves. So this table shows the three types of hybrid studies. So just real quickly, the hybrid type 1 is really looking at effectiveness as the primary outcome and collecting data around implementation. So it's not even really necessarily testing an implementation strategy at all, but really kind of collecting some key contextual data. So a lot of times it's those determinant factors. What are the barriers? What are the facilitators to implementation that gets collected in the hybrid type 1? The unit remains kind of the standard kind of patient usually, and the main outcome measure, the primary outcome measure, are usually patient symptoms or functioning. And then again, standard designs for the hybrid type 1 are randomized controlled trials, typically powered at the participant or patient level. The hybrid type, I'll go to the hybrid type 3. So this is the opposite, right? The primary is really the implementation outcome, and you are also collecting some secondary effectiveness outcomes. But really, the main point of the trial is testing an implementation strategy. Typically, hybrid type 3s would be, you'd be looking at the unit of comparison would be the provider or a clinic or systems of some type. Often these are a number of clinics that are randomized, often in cluster randomized trials of some sort. The implementation outcome is the primary outcome. So you're looking at things like adoption of the intervention and fidelity and outcomes around the implementation strategies themselves. And then the hybrid type 2, which I think is sometimes the more challenging one, it's really co-primary outcomes. You're really, you're looking at both effectiveness and the feasibility of implementation strategies. And then you can see these combos. You can kind of go one side or the other in terms of what is going to be the unit, what is the comparison condition, and what are the measures, because you're really looking at both things equally to some degree. So, so while specific research designs, again, are not necessarily tied to a hybrid study, different research designs have more or less utility for each type of study. I think in particular with the hybrid trials, as opposed to standard effectiveness trials, you're really utilizing theories or models, implementation theories or models to guide key aspects of the research. That should be included. You are clear on your differentiation between the intervention components and the implementation strategies. Those need to be clearly spelled out. And you really, especially in the type 2 and the type 3, you want to fully describe the package of activities that make up the implementation strategy. All right. And this I found particularly helpful. This is in a recent paper published by Curran and colleagues, in really thinking about a hybrid study type. What are some of the questions to think about in terms of selecting one over another? So really thinking about the effectiveness data. How much effectiveness data do we have that really can kind of drive whether it's a type 1, 2, or a 3? Obviously, if there's less effectiveness data or none at all, you're really looking at a type 1. If you have quite a bit of effectiveness data, then considering a type 2 or a type 3 might be appropriate. How much do you expect the intervention will need to be adapted in the settings that you're going to be studying? Greater adaptation, you might move more towards a 1 or a 2. Less adaptation, you might consider moving to the 3. How much do we already know about the determinants? Do we have good information on the barriers and facilitators? And how ready are you to evaluate a real-world implementation strategy? So do we have strategies picked out that we think are going to really work? Maybe we have some data on those. That would move you again more towards the hybrid type 2 or a 3. And then just to close out here, the last couple of slides. So we have these hybrid trials that combine the effectiveness and implementation, again, trying to cut down on the amount of research time before something can be scaled up. We can also think about even earlier in that pipeline during our efficacy trials, for example, exploring implementability earlier. So again, we know that without some of this implementation information, there's often poor fit. And if we can collect some of this information earlier, we can consider it from the outset. That might give us better information in terms of how we need to develop, adapt, tailor our interventions to better fit the community context. So concepts like, designing for dissemination and implementation. So you're designing that intervention with the idea of dissemination and sustainability in mind. You're prioritizing collaborator perspectives. So I think community engaged research in its various forms is starting to take or have it more of a moment in the sun. And I think that is to help us really with some of these issues in terms of what's going to work well in the community. And then to collect data during intervention development, evaluation, implementation, and specifically around these ideas of acceptability, fidelity, and feasibility. So these are some real core concepts, constructs that are really primed to collect information on earlier in the pipeline. So I'm going to stop there and turn it over to Jennifer to talk a little bit about her research, and then I'll look forward to coming back together at the end and kind of thinking through these and some examples of in your own work. So Jennifer, on to you.
Thank you so much. Thank you for that excellent intro. I'm gonna see if I can get this. Can everyone see okay?
Yeah.
Okay, thank you. So I can't see anyone, so verbal response, please. So the plan for my part of the presentation is that I'm going to talk about my K Award project in Mozambique, and the idea behind that is to illustrate in on-the-ground, real-world application, how we've integrated implementation science, where we have found there to be gaps, and how we've addressed those, and how it's informed the design of our pilot trial. So first, this is a K23 award that is funded by the National Institute of Mental Health. And I'm going to try to keep this presentation to about 20 minutes, so I may breeze through some slides here, just set my timer. And here's a snapshot of the advisory team. So Dr. Milton Weinberg, who many of you probably know, is my primary mentor. And then there are other experts in couple-based domestic violence, psychotherapy, men's mental health and engagement of men. We have Myrna Weissman, who developed interpersonal psychotherapy, which is the intervention that we have selected to work with couples. Palmira Santos is my main collaborator in Mozambique on this project. She's a sub-award PI and does a lot with this project. Also, she's an expert in the Mozambique mental health system. And then Dr. Niall Bolger, who some of you may know, who's an expert in dyadic analysis. And here's a quick picture of our local team. Let's see, and the picture on my left is the project coordinator, psychologist Katia Santos. And on my right is the national trainer and lead for interpersonal psychotherapy or interpersonal counseling. So she's our lead trainer in this study. So I have just 3 quick slides to give some context, otherwise might not make sense why we're selected this intervention, or when I talk about implementation, why that matters. So the focus of the intervention that we're piloting essentially is to reduce intimate partner violence in couples. And the reason is that we know intimate partner violence is a significant public health problem globally. So 1 in 3 women globally experience intimate partner violence. And then you can see the darker red, the darker the hue, the higher the rates are. So in places in sub-Saharan Africa, I've also worked in Uganda, rates are as high as 75%. We found that in our own work. And in Mozambique, where I'm working now, rates are about 50% of women report experiencing intimate partner violence. I think it's a no-brainer that intimate partner violence negatively affects women's mental health. This is just an example of some of our work from Uganda. This is a qualitative study where we asked women to describe their experiences related to intimate partner violence, and they described having a constellation of mental health or emotional constructs, such as lots of thoughts, heart pain, anger, that sort of all went together and could lead to thoughts of escape or trying to escape physically or literally, and or escape through suicide. And this affected people's ability to work and vice versa. So what that means for practice is that we know intimate partner violence is common globally, especially in many places in sub-Saharan Africa, that many treatments focus on reducing symptoms on an individual level. And there are fewer interventions that actually focus on reducing the problem itself. So interpersonal psychotherapy does work with disputes and disagreements with partners, but typically from an individual perspective. And so there's only so much that can be done in an intervention in an individual way. So we've decided to adapt that intervention and work with couples to try to reduce intimate partner violence and improve mental health. Which brings us to our pilot trial in Nampula, which is in the north of Mozambique. It's called the Capital of the North. Nampula City is an urban center. It's the third largest city. So we have numbers here, but I think actually it's closer to 1 million people live there. It's very diverse. So the main ethnic group is Imakua, but also lots of Lebanese, Indian, European, and Chinese people live there. There has been an insurgency in Cabo Delgado, which is the province directly north of where we've been working, and which has displaced that, and 2 cyclones in the last couple of years have displaced over 1 million people, many of whom are coming to Nampula province, many of whom are relocating in Nampula city. It's matrilineal, which is sort of interesting if we think about intimate partner violence and gender role norms and socialization. So we felt that it was important to explore what that meant in that context. And also it's the site of 1 of 2 psychiatric hospitals in the entire country. The other one is very far south, close to South Africa in Maputo. And then the second is in Nampula. The overview of our research aims and timeline. So we started by looking at contextual influences. So this is all about implementation. We use the CIFER framework, which I'll show in just a little bit. And we had a focus on identifying gender roles within that framework. We then worked to adapt the intervention to reduce common mental disorders. That would be depression, anxiety, and PTSD in women, through resolving or improving intimate partner violence in a couple format. And we're just getting ready to do our pilot trial, which focuses on acceptability and feasibility. So Aimee showed that nice graph and continuum. We're sort of at the beginning. We don't have very much effectiveness data about whether this type of intervention would work. But even before that, we want to figure out if this is acceptable and feasible. This is a community partnered project. So we have representation from policymakers and Ministry of Health representatives, researchers, and district and local officials. We meet with our community advisory board several times throughout the year. And we also have a community partnered team. So these are experts nationally who are experts in the intervention that we're adapting. So throughout the whole process, we show our findings about implementation and adaptation and what people say about the intervention itself, and we work with them to adapt the intervention and treatment. The first objective, again, was to identify gender roles. So this is about implementation, including local contextual influences relevant to engaging men primarily, but we also looked broadly at implementation factors. I'm happy to say this project started during COVID, but we finished this phase and we conducted 11 focus group discussions with very diverse representation with community leaders, elders, district officials, providers. That was mostly psychologists and people who work in mental health, or they have a specific program in gender-based violence. So we interviewed them as well. Community advisory board members and gender segregated groups of men and women who were recruited through hospital waiting areas. And we also conducted 8 individual interviews with key informants. Typically, these were people involved with mental health or intimate partner violence at a policy or leadership level. In total, we had a sample of 85 participants, and we adopted a strength-based approach, meaning we asked a lot about strengths that we could leverage in implementation. So Aimee gave a nice overview of the CFR model, and where we really wanted to hone in or zero in on was the outer setting here. And this was mostly because we were interested in looking at gender roles and the other intersectional identities. And we found this to be a pretty significant gap in some of the implementation frameworks, including the CFR. So it covers, as you can see, so many broad constructs and domains, but because we were interested in gender very specifically, we found that to be a gap. And there's a very nice paper written by Tannenbaum and colleagues that talk about this gap, and they talk about how gender role socialization influences preferences, acceptability of interventions, the uptake of them, decision making. So where we work, for example, both in Mozambique and previous work in Uganda, showed that men often made the healthcare decisions in the household, and women needed to negotiate for their own healthcare or their children's. Also, stakeholder engagement. So who is involved in leadership, who is involved in designing and implementing some of the strategies, and communication. And ignoring this, they mentioned, can harm participants. Ignore them, but harm them potentially as well. So given this gap, we applied a masculinities lens, and I'm just going to talk about some of our findings, not all through the CFR, we would be here for a long time, and we looked at other kinds of things that relate to intimate partner violence and mental health, such as HIV, pregnancy, etc., and looked at special considerations for implementation given these co-occurring conditions. But I'll focus on some of our main findings in the outer context and what that meant for us in terms of our recruitment strategy and how we've adapted. So the first one, looking at gender roles, as I mentioned, this is a matrilineal population. So it's actually different from the south of Mozambique, which is patriarchal. And it's situated, there's a belt of ethnic groups that start at the Indian Ocean, but go all the way to the Democratic Republic of Congo. So we wanted to figure out what that meant for this context in terms of help seeking, what does it mean for gender roles, dynamics in couples, etc. But what we came up with was a pretty traditional interpretation, at least in terms of gender role socialization. And people talked a lot about machismo and what that looked like and how that was a barrier to help seeking, especially for men. So here's a quote from a gender-based violence expert that says, "Your sexist side that says, I can't expose myself. I can't say this to a person like me. Maybe he'll notice me as a weakling, among other thoughts, and that can make it difficult." So there's a vulnerability of sharing difficult things or presenting with a quote unquote weakness. And the other interesting thing that came out of this was a lot of discussion about, the power dynamics that are inherent in the healthcare system. So they talked about, many people gave examples of men in the community setting, because in the communities in Mozambique, there's a person who's elected by neighborhoods. They're called the neighborhood secretary. And usually this person, dispenses, if there's like awareness campaigns or other things, this person might organize that for the neighborhood, and people will come give talks and provide education. So people gave that example a lot in terms of men not wanting to attend these educational programs, and they use the word influence, that men don't want to be influenced, they don't want to take advice, and then they sort of related that to the hospital and healthcare system. So here's another quote from an expert in gender-based violence that says, "But if the wife says to the husband, let's go to the hospital for advice, the man can say, what am I going to do there? What are they going to tell me there? The nurse will tell me what." Other specific things about the socio-political context that came up for us were about stigma of experiencing intimate partner violence, but especially around reporting it. So we have traditional masculine norms as one barrier, but also there were barriers for women in terms of reporting. So a quote here says, when one goes out and goes to report it, all the others will say, you don't love your husband, you are not a real woman. What kind of woman are you to denounce your own husband? So there was lots of discussion about, this social pressure for women not to talk about violence outside of the home, which we've heard in many other places around the world, but there was significant pressure and they might be labeled as gossipers or not as a good wife. There were also very practical considerations that people mentioned. This had to do with women's livelihood and being potentially dependent on their male partners for their livelihood. So this is an example that says, if my husband beats me, I won't report it. I can't put my husband in jail because he's the one who feeds me. If I complain about my husband, what are you going to feed me? He's my husband. I shouldn't say anything. So very, huge barriers on both sides. Barriers for men in terms of seeking healthcare, but also many barriers for women as well. And the last thing that I'll share is not as much about the sociopolitical context, but more about, I like Aimee that you call it the thing. I hadn't heard that before, but the innovation, or in our case, this would be the psychotherapy that we're using for couples. And people talked about a traditional pathway of resolving disputes among couples. So if there was some kind of dispute, usually the men's family would be brought in that case. It could be uncles or brothers, and they would give advice to the couple and try to help them resolve the situation. But it's very rare that couples talk directly, especially women to men. And if it can't be resolved through the family, then people go to that neighborhood secretary that I mentioned before. So they go out to the community and they try to have an elder or this neighborhood secretary will come and meet with them and maybe their family too, to try to help them resolve. So that's already a couple of steps. And really in only extreme circumstances will people go to the hospitals, which is where we're set to implement this intervention. Part of that, there were lots of concerns about safety given we're working with violence. So we didn't adopt a task shifted method, which might be use of community health workers or primary care providers, but we relied on use of psychologists who are mostly based in hospitals. And there's a lot of stigma of going to the hospitals for mental health. People, they say things like reserved for the crazy, very severe mental illness, and people didn't want to be associated with that. And it's very rare that people will go for intimate partner violence or some kind of dispute unless it's very, very severe. So what people said about that was that there's a relative advantage of having a psychotherapy that could help address violence in couples and improve mental health, but they also were wary about how to get people to come into the hospital setting. So based on all of this feedback, we held a series of community meetings. And this is one community meeting that we held. These mostly consisted of the neighborhood secretaries who had a really important role in helping to resolve disputes, but also maybe provide education to couples about potentially going to the hospital if they wanted. And we would like to, based on these meetings, we're going to now start recruiting from the community settings. The other thing we talked about with these community leaders was about severity of violence, because we have to be very strict about who can be included or excluded. This study treats mild to moderate violence, and people who have extreme violence are not a good fit for this kind of intervention. So we screen people out, but it's based on a measure that is used in a high income setting, actually was developed in the US. And we got a lot of feedback that there were some items that talked about violence being severe, maybe in the US context, but were not considered severe. So we took those items and had people sort of rank them and discuss whether or not they thought, how severe they were and whether people could participate in a couple-based intervention. So based on all of that, we have a new proposed flowchart of community recruitment. So we've decided to stay with the hospital, although we already have some information about feasibility in a hospital setting. And I think next steps for us would be to go outside and deliver this intervention in the community. But given where we are with the project, and the training takes quite a while to train an intervention and supervise people so that they're competent in delivering it, we're sort of out of time. So we're trying a new recruitment strategy to see if that would help. And if not, then I think we'll need to go back and consider delivering this intervention in a community-based way. But essentially now when couples go to the neighborhood secretary, the secretary calls or communicates with the research assistant from the study, who will go there to the couple and the neighborhood secretary, find a place to do some screening and refer to the provider at the hospital if they agree to participate. So all those amendments are under review now through IRB, and we're sort of paused, trying to make the strategy more feasible and acceptable and fit better with the local context. So thank you. That's all. That puts me right at 20 minutes. Thank you so much. I'm going to turn it over to Justin now.
Great, thanks, Jen. Can everybody see my screen? Great. Yeah, that was, I learned so much about your K, Jen. I'm hopefully not going to talk as long because we were hoping to have some discussion. Interestingly enough, I'm also doing a hybrid implementation effectiveness pilot trial for my K, but my contribution here today is actually around prioritizing implementation science data collection in the context of conducting observational research. And I can maybe get into a little bit of how I got there, but some reason okay, there. I was able to get my slide to advance for a second. So yeah, and I've presented on the paper that sort of laid out our arguments for why we think there should be an observational implementation hybrid approach. I presented on it in the spring at the HIV Center Grand Rounds. Hopefully, I think a lot of the people on at this workshop today were there, but I'll just quickly walk through it, talk through some of how we're applying it, just to give some examples of some of the considerations when we decided to integrate implementation science data collection into an observational cohort using this approach, but really hopefully leave time for discussion around what we think are next steps or potential next steps or I think areas that need further thought with regards to this approach, but in general too. So yeah, this paper is out in Annals of Epidemiology. There's the citation information, and we also recorded a podcast sort of about like behind the scenes writing the paper with Patrick Sullivan. That was kind of fun to do. Yeah, so as Aimee presented, right, implementation science is, the study of methods and strategies that facilitate the uptake of into everyday practice of evidence-based strategies to improve public health or clinical practice. And then Jen gave that really nice talk about how she's collecting relevant implementation science data as part of her trial and in preparation for her trial. And then our paper is really providing sort of a theoretical justification for why we think researchers should incorporate implementation science methods and measures into observational studies in order to collect information that it would allow them to anticipate, estimate, or infer about the effects of interventions and implementation strategies. And, you know, trying to tie it back into what Aimee was presenting on, right? I took this slide from her presentation, right? And our thinking was, right, that if our goal really, or if one of our agreed upon goals is to accelerate this research pipeline, the translation pipeline, then hybrid effectiveness implementation studies are really only accelerating like one portion of it, right? Going from efficacy or effectiveness trials to the implementation D&I research, right? Whereas, could we start doing it earlier when we're thinking about preclinical or before we get into the effectiveness part, right? Could we understand before we get to the trial phase whether or not someone would be interested or willing to uptake a certain type of intervention, or would it be feasible to use a particular implementation strategy? And then we also know that there's certain exposures that there aren't things that we can randomize, right? So I do a lot of research on substance use, right? You can't randomize people to use cannabis versus not. But you might, in the context of studying something in an observational context where it can't be randomized, you could still, in that context, start to collect information about what participants' willingness would be to reduce their cannabis use, or what their interest might be in in discussing it with a provider, or what access they would have to potential interventions. So I still think it's a relevant context to collect implementation science data. And so then in the paper, we provided sort of 3 broad contexts where we think the observational implementation hybrid approach would be relevant. Because I'm trying to keep it brief today. I'm not actually going to get into the details of each of these, but it's laid out in the paper. One is in the context of conducting observational studies that individually enroll participants and provide a natural history of their experiences or behaviors. Measures could be added to those assessments to understand acceptability or appropriateness of relevant evidence-based practices, depending on what the salient issues are. A second context is when there's routinely collected program data. And then a third context is collecting data from participants in observational cohort studies who are also involved in study-linked interventions. For example, we do a lot of HIV research, right? HIV service settings are an important point of contact in order to recruit participants, and very rarely are questions asked during the surveys about those experiences with those, accessing those services, so, and rarely is that data linked, right? But it's, just presenting at that setting or that site could be an opportunity to collect data to understand, what brought that person to that setting, and linking those data so that you could, learn more about, an intervention related behavior. So, one thing we agreed would be important when applying the observational implementation hybrid approach is to have a knowledge of the intervention and implementation landscape. Being trained as an epidemiologist, I don't think that's necessarily part of how we're trained. So it's a consideration when we think about putting our teams together and who we want to engage with, either learning about that or involving people who do have a better understanding of that. And then incorporating, relevant implementation science methods and measures into those data collection processes, right? So Aimee did a really nice job of orienting us to some of the, prevailing implementation science theories and frameworks and some of the relevant constructs. As she noted, some of them can be quite complex and maybe even off-putting to people not very familiar with it. And one of the things, we point out in the paper is that you know, one way to perhaps improve dialogue or increase, you know, collaboration between those doing implementation science research and people doing observational research that don't see it as relevant is sort of simplifying things and having, you know, less complexity. And then there's also, you know, other things where observational studies are well suited to collect, you know, factors related to transportability, you know, certain selection factors that have known to be associated with the effectiveness of an intervention. It could also improve actually what's oftentimes trying to be estimated when conducting observational research, which is the, you know, population attributable risk of an exposure on an outcome. Observational studies could also be used to measure participants' willingness to engage in interventions, perceived acceptability, factors related to access or uptake. And we also is an opportunity to get end user perspectives to help shape and adapt things that could potentially be implemented to address salient issues. So an exciting aspect of this method that we proposed is that we're actually, you know, in the process of implementing it. I'm one of the MPIs of the Networks and Neighborhoods Part 2 cohort study, which is an HIV status neutral cohort study being conducted among Black sexual minority men and transgender women and other gender expansive populations in Chicago, Illinois. We've recruited over 600 participants and we'll be following them for another 2 waves, so over the next 2 years. This is the conceptual model for N2P2. It's the aims are to determine the causal effect of substance use as well as sleep on HIV outcomes. And so in this context of studying the relevance of substance use in particular on HIV-related outcomes, we're hoping to not just identify causal associations between these constructs, but we also want to collect data that can be used to inform how to deliver evidence-based interventions that'll address some of these salient issues. And in particular, we're doing that with regards to alcohol use right now, and we just describe this in the protocol paper that's you know, in the title here that recently was published in JMIR Research Protocols. So yeah, just some background. We know there's high levels of past month binge drinking, of heavy drinking among Black sexual minority men and transgender women. We also know there's a high prevalence of past year alcohol use disorder from other nationally representative data. And I've led a review paper on the range of evidence-based practices that exist to address alcohol use, both in terms of screening as well as treatment. And that includes, you know, pharmacotherapy, talk therapy, support groups, e-health and mHealth tools. And many of these go underutilized, right? I think this is a common problem across health issues, is that there's a big implementation gap, right? So this is that same NISDU data showing that less than 10% of individuals with an alcohol use disorder receive any treatment for it. And this is true among Black sexual minority men. We actually don't see huge inequities here. And in our study, in the N2 study, where we're also focused on HIV-related outcomes, we also know that alcohol use is associated with worse outcomes across the HIV care continuum. And there's also emerging evidence that it's disruptive to PrEP related outcomes, both in terms of uptake, adherence, and persistence. So conducting this observational study, we don't just, you know, we know alcohol is a salient issue. We know there's harms related with alcohol use. We know many people with problems related to alcohol use don't receive treatment. So can we use this opportunity to not just find out, you know, whether or not there's a causal association between alcohol use and HIV-related outcomes, but can we collect data that will allow us to inform future intervention or implementation? And so the one way that we've operationalized that is we got a pilot study funded to incorporate a discrete choice experiment into this current round of data collection. So right now we're And that was a process, like just stepping back to like, these might be methods that we don't just know how to use, the benefits of being on a K and going through some of these training processes is, being exposed to new methods and learning what they are, but also learning how to develop one. And, we had a lot of consultations with subject matter experts. We workshopped with our community advisory board. We did a bunch of cognitive interviewing to make sure participants understood what a discrete choice measurement was, and now we're implementing in the the current round of data collection for N2P2. And for those not aware, discrete choice of experiment is an implementation science approach that provides preference data, in this case on how to deliver alcohol interventions for Black sexual minority men. A discrete choice experiment can use to explore preferences for who a person would like to discuss their drinking behaviors with, in what context, what type of intervention they might like to receive, and the frequency of engaging with that intervention. And it does it by breaking those down into different attributes with levels, and then performing a series of experiments where people ask, basically randomizing different combinations of these levels and attributes, and asking participants to select which one they would prefer. And what emerges from that is, what are the preference driving criteria that would encourage someone to engage in that type of intervention. So that's been an exciting project. And then we also, among a subsample of N2P2 participants, we recruited them and did some human-centered design work with them, really focused on journey mapping. So asking them to describe their physical and emotional journey as they access HIV prevention and care services. And then we also linked recruited providers that are linked to some of the recruitment sites for the study, and asked them to provide their physical and emotional journey, providing HIV prevention and care services to Black sexual minority men and transgender women. And that data actually was just presented by a mentee at the Society for Behavioral Medicine meeting that happened last week. Really created some nice visuals, like helping to see what participants' experiences are like in those settings, and where there could be opportunity to screen for and offer intervention. We're focused on alcohol use, but actually what emerged is that, there's a number of, related health issues that people would like to be offered in those settings, including, related to mental health, anxiety, depression, as well as physical material support. So that work's been really exciting. I think it's providing some, innovative and hopefully, useful data in terms of informing follow-up intervention and implementation trial work with this cohort. But there's also a number of discussion points, I think, related to, just in general about the utility of the approach, but also how we're doing it. Writing this paper about, specifically focusing on expanding implementation science data collection into a type of, study design where I felt it had been under prioritized, has sort of led to a number of discussions, just thinking about the dissemination of hybrid approaches and implementation science in general. So I think certain groups have embraced it more readily than others, right? Certainly like trialists and interventionists, more so than those conducting observational research, but also certain fields like economists versus, public health practitioners. Even within public health, we notice certain institutes like NIMH, being more supportive and excited about it than NIAID or, other institutes. So just, some reflection on why that might be, and what might be factors related to that, and could there be ways to help further disseminate, what we think are useful methods, and methods that can hopefully help, address this, implementation gap, as well as, accelerate the translation to research pipeline or research to translation pipeline. We still feel like it would be useful to have more examples of how, hybrid approaches can be done in this context of conducting observational research. The one I described is really more of that first context where it's like an observational study where you're enrolling individual participants, and even like the human-centered design work is really among a subsample of that, So I think, more examples of how it's being done or how it could be done, how it might need to be adapted for other settings. A big thing that we talked about in terms of the effectiveness implementation approach is the typing and how you prioritize implementation versus, effectiveness outcomes. And should there be something like that similar for, for people that want to do observational research, but also incorporate implementation science data collection? I got to at this a little bit, but what, are there implications for how public health folks are trained and how we're exposed to implementation science? I know I, feel like I hadn't heard much of this until I was a postdoc, and kind of wondered why that was, but there are emerging programs, right? So dedicated to implementation science and even getting integrated into other settings. So just thinking about, how that should happen and how that's done. Are there, we had a piece in the paper about, if there's longstanding health inequities, is there even more reason to prioritize hybrid approaches where there's more of an emphasis on translation? And then, the timing, how early can you start to collect implementation science data? On Aimee's figure, even at this preclinical settings, I was talking with Jay Sabelis about this, even the way some of these, preclinical trials or phase 1, phase 2 trials are being designed to study psilocybins, how are those designed and constructed, and are they being done in a way that, would be inclusive once they go to get, if they're shown to be effective, start to be, scaled up and evaluated in a larger, setting. And then lastly, sorry, I'm jumping all over here. I think there's some thought, as epidemiologists, like I mentioned, the thing we're trying to estimate oftentimes is this population addressable, attributable risk. But could we actually refine that estimate to be a population addressable risks, not just like this is how much of this, outcome would be, can be explained by by this exposure. But if we also knew that, only half of the people that were using cannabis use would be willing to reduce their cannabis use, or that the effectiveness of the interventions that we're considering are, could we incorporate that data? If we incorporated that data collection into those study settings, we could actually, create, I think, even more informative inferences from our data. So, sort of like a wonky epi paper that I think could be written. So I just wanted to sort of share my brainstorming around that with folks, with the hopes that maybe we can use these last 15 minutes to have a bit of a discussion.
Thanks, Justin. And I think, yeah, we want to just open it up and see if folks have some initial thoughts and comments. And I think one thing also we were interested in is maybe continuing this conversation offline after this workshop. And is there, kind of a subgroup of us that would like to maybe meet on a somewhat of a regular basis to continue these discussions and really think about how do we incorporate this into our work in a way that's systematic and can kind of move the field forward to some degree, or we're just curious about how we can do it.
Yeah, thanks to all three of you. I certainly learned a lot, and there's a lot of expertise here that I think we can all benefit from. And